Thank you very much, Richard, for that very kind introduction, and what an honour and a privilege to be able to present the highlights of this 50th spring meeting. We're going to take it in turns, so bear with us. Strap in, because it's a roller coaster through 4 streams over 3 days. Lots of highlights to come. Some declarations, but nothing really of any significance for what we're going to say coming on. So overall there were 82 proffered papers, 65 invited lectures, representation from all across the globe, 111 posters, which I think is a record for these meetings, which were highlighted yesterday. And as I said, it's the 50th annual meeting. Reflecting back, the first meeting was actually in 1966 at the University of London Medical School. So, how to start? What do we do? Not an easy task. I have to say this is probably the only meeting I've been to where I feel like I will be getting over 100 hours of CPD. Basically, we have poured through all of the available lectures. Unfortunately, not all of them were available, so what we're going to highlight is what we had to work with, and we've tried to pragmatically divide this up into key themes. I'm going to open the batting talking about diagnostic clinical applications. Sabina will then follow on with the therapeutic aspects. We'll then talk about some cutting-edge presentations, and finally we'll end with workforce and education. So without further ado, the cardiac offerings from the meeting included a dedicated session on cardiac inflammation, particularly focused on the utility of FDG PET. There were multiple proffered papers looking at a range of topics, particularly the use of FDG PET-CT in cardiac sarcoidosis, the accuracy of rubidium imaging for determining left ventricular ejection fraction, and the use of DPD scintigraphy in patients with suspected amyloid affecting the cardiac system. So this first paper from Liverpool was a 7-year retrospective review of their experience using FDG PET in patients with suspected cardiac sarcoidosis, and they reviewed their series of over 200 PET-CT scans and found that this had a high diagnostic accuracy with a yield of nearly 92%. There was a smaller number of patients who had non-diagnostic scans, which was about 8% of the whole cohort, which was below previously reported levels for indeterminate scans. And what they found is that some of these patients had follow-up studies and they were also non-diagnostic, so it's not just the preparation. Some patients just do not lend themselves well to this technique. A group from St Bart's looked at quantification of FDG PET in cardiac sarcoidosis and developed a mechanism for dropping volumes of interest on the cardiac area and then quantifying activity in terms of total lesion glycolysis and assessing using different thresholds. And found that this was useful for monitoring disease activity through treatment and shows promise for the future. The same group also looked at work comparing the use of rubidium PET for determining left ventricular ejection fraction with other more conventional methods such as cardiac MR and echo, and they studied 62 patients who had had rubidium PET-CT scans and also cardiac MR, and they found a good correlation between the ejection fraction measured on the 2 different techniques. Similarly, for patients that had had echo, there was a good correlation between the 2 studies, so that's reassuring to know. In another paper from the Liverpool group looking at the utility of DPD scintigraphy in cardiac amyloid, they reviewed their experience over the preceding 3 years and found that actually the use of planar scintigraphy was sufficient in the majority of cases where they're able to visually score the degree of activity within the heart. And actually, whilst protocols suggest doing SPECT-CT, this was only necessary in a handful of cases, and so may provide some efficiency in terms of scanner utility. Moving on to endocrine offerings, there were proffered papers looking at contrast-enhanced sestimibie SPECT-CT in parathyroid localization, choline PET-CT in parathyroid imaging, and a novel analysis of tectoid scintigraphy using a quantifiable method. So the question posed by this group from Newcastle was, does adding contrast to parathyroid SPECT-CT increase the accuracy? And what they found in their group of patients was that in about 8% there was a tracer negative parathyroid lesion that was more confidently detected and characterized with the addition of contrast. Similarly, there are a number of lesions in patients where they had low tracer activity, and the contrast added confidence to calling that as an adenoma. So it's only a sort of marginal gain, but it does look like it may have a role. There was a very nice detailed investigation of a parathyroid SPECT-CT, which had an artifact which we've just heard won a prize for the young investigator, where they did a really nice phantom study to try and detect what was causing this truncation artifact, which I won't go into much detail, but if you're interested, there are, the slide sets will be available after the meeting. This nice work from the Imperial group looked at the impact of fluorocholine PET-CT, but in particular in the era of digital PET and the reconstruction technique, they wanted to find out whether this had a bearing on the detection rate and reader confidence. In particular, the use of these digital detectors can reduce the noise in the image and improve signal-to-noise ratio, but it may introduce partial voluming effect, which can reduce the conspicuity of small lesions, as illustrated by these examples on the right-hand side. And what they did is they looked at 3 of the routinely provided reconstruction algorithms and evaluated which of these were felt to be better for detecting lesions. And you can see as you look across those 3 images, the detectability visually is much better using the all-pass or unfiltered algorithm. And this is nicely illustrated in this case, where you can see the lesion on the far right is much more clearly depicted with that algorithm. So their summary was that they would change to using this all-pass algorithm, and that increased their detection rate significantly, up to 86%. This nice work from a group from Glasgow looked at inter-rater variability of visual Krenning score from ultraretide scans using tetrated, and they had developed a quantitative method of analysis as a comparator. So what they did was they used LifeX, which is an open source software that's freely available, and used a threshold of 40% of SUV to segment the lesions and derive a quantitative value from it. They then compared that to an expert panel of 3 nuclear medicine physicians visually scoring, and what they found was that the Kappa agreement was about 0.8 for the quantified SUV max, but the Kappa score across the sort of qualitative scoring was much more variable, and this could potentially be a way of easily improving the technique going forwards. In general nuclear medicine, there were some interesting offerings, particularly about the potential benefits of quantifying SPECT for distinguishing between malignant and degenerative bone lesions, which has just recently been announced as one of the prize-winning exhibits. And this came from the Bath group, looking at analysing standardised upload values from areas of malignancy in patients with cancer and also degenerative areas on the bone scans, and they found that you could clearly discriminate on the basis of the SUV values between metastases and degenerative change, so this might have some value going forward. There were two nice papers that looked at quantification of lower limb lymphocytography, and this first one actually was a really novel use of diagnosis of phlebo-lymphedema, which I have to admit I hadn't heard of before this meeting, but effectively this is when you have chronic venous insufficiency and it can influence the lymphatic flow, and it actually speeds the lymphatic flow up. So rather than what we're usually looking at, delayed transit, you paradoxically see more prompt transit, and you only will reliably see that if you start to quantify things. So you can drop regions of interest around the inguinal nodal basins and quantify the activity, and then use that an ilioinguinal nodal percentage of injected tracer activity as a metric to see whether the transit is rapid or not. And in their group of cases, they actually were able to detect increased flow, which correlated with the underlying pathology, which was due to venous insufficiency. So quite an interesting analysis. A similar paper from the group at UCL looked at quantification using a very similar methodology, but this time looking at increasing the diagnostic yield for patients that have got slower flow, but that's not necessarily as visually apparent. And in their study of 60 patients, they found that about 20% of them had a discrepancy between the visual and quantitative findings, and in some of them, cases that were called normal were actually re-evaluated and found to be abnormal. Moving on to the PET domain, there was a plethora of high-quality presentations on the use in prostate cancer. There was a dedicated masterclass, and then several papers about the use of PSMA PET-CT, which I'll briefly run through. This paper from the Southampton group looked at determining real-world thresholds for positivity in patients with biochemical recurrence of PSMA PET, and when the availability is still relatively limited, it's useful to have a balance between achieving a positive scan and not doing too many scans where you're not going to actually influence management. The very recently updated European Association of Urology guidelines recommend using a threshold of 0.2 for PSA in patients that have had a prostatectomy. And in fact, in their group, they found that this worked out as 0.23 for their group to have the best compromise between positive scans, and so it looks like it holds good. This was a nice paper from the Cardiff group that looked at staging of high-risk prostate cancer using PSMA 1007, and whether there were clinical predictors that could help increase the utility of the technique, again because of the shortages in supply at the moment. And what they found was that the metastatic disease was more prominent in patients that had higher Gleason score, but there wasn't really a direct correlation with PSMA, with PSA level or the staging on MRI scans, so they couldn't really be used to stratify who to use them in. This nice work from Imperial looked at using delayed sequences for PSMA PET to try and problem solve. And in their series, they showed nice images of cases where there is focal uptake in the prostatectomy bed, which is difficult to differentiate between urinary excretion and recurrence. And on the delayed image, you can see this intensifies and is tumour. In this other case, there was a challenge about whether this was ureteric activity or a lymph node, and the delayed acquisition helped. But there are practical issues about how you would manifest that in your routine practice, as most centres are receiving fluorine-labelled tracers in the afternoon, and doing extended imaging into the evening may be challenging. Their other paper around PSMA PET, which won a prize just announced this afternoon, looked at the correlation between multiparametric MR and PSMA for localising local recurrence in the prostate, and they found that PSMA PET was highly sensitive and had greater sensitivity than MRI alone, but it also detected lesions where the MRI had not seen a lesion at all. So it looks like it's a very useful technique. So with that, I'll hand over to Sabina.
Thank you all for staying for highlights lecture, and thank you, Richard, for a lovely introduction. We had the idea to be like here as just in tandem doing a stage performance, but obviously it's not practical. So, but might be good just to wake you up once when we get into high science and cutting edge. So this slide is from Professor Andrea Igaro, who presented just today. So for those who were not here, I included some slides in his lectures, in our lecture as well. And clearly we all know that success depends on people, collaboration, space, equipment. And really thank you for lovely talk, presidential, and I think that's what you also emphasize. So basically we are really growing, and I think it's the most exciting time that we are going through. We've never been so popular with our colleagues, clinicians, with our students. So I think we need to embrace nuclear medicine, which is growing everywhere in the world, as it's been shown here in Stanford as well. So I'm going to talk about molecular radiotherapy and highlights from this BNMS, and to mention that now we have an interest with so many different groups want to actually be involved, and MRT consortium was established between oncologists, nuclear medicine physicians, radiologists, scientists, physicists, radiochemists, with some strategic mission to actually try to provide better access to molecular therapy. So this access actually is really absolutely required in the UK, and you know that infrastructure is limited, and we all need to work together. So we're hoping that BNMS will be umbrella, and all molecular radiotherapy clinicians will be involved. And our good old iodine is still very controversial after 82 years of treatment. So Fahim Al-Hassan from GUYS gives fantastic overview and controversies and trends that are currently still developing, and it's quite hard because there are different indications, and sometimes during the MDMs we actually now following obviously nice guidelines, but there are different risk assessments, and in literature I have found 70 risk assessments for the thyroid cancer patients. So this is just proof that even after so many years of routine clinical use, we still need to improve, and we still need to research. So out of thyroid patients, we always have a problem with predicting outcomes, particularly post-treatment, and this was very nice paper from Glenn Flack's group, Jane Toprod, who actually talked about a combination of post-operative thyroglobulin and absorbed dose to the thyroid that can predict radioiodine therapy outcomes in differentiated thyroid cancer patients. And this is a large study planned to include 100 adults with a differentiated thyroid cancer. And it's actually an international study, which is also very interesting and commendable. And they actually already have preliminary results, but we are waiting for final results. And basically, they propose that post-operative stimulated thyroglobulin could be promising surrogate for volume to obtain relationship between absorbed dose and outcome, and to allow for patient-specific treatment planning. So this is a novel. Prostate cancer masterclass was fantastic, organized as a multidisciplinary team meeting, and Professor Amit Baal presented a lovely talk on the management of prostate cancer, and can we really see the wood for trees? We need to be involved in uro-oncology multidisciplinary teams, and I know that many of us are already involved, and it's fantastic to see growing interest within oncology community for BNMS. So basically our treatments such as radium and PSMA are just put at the last stage after usually two treatments already failing. So basically we will need as a community to support trials to actually develop our further treatments at the earliest stage. And not just that we can help with the treatments, we can help with the imaging at different stages, and not just PET, then SPECT. And as we could hear that actually PSMA SPECT CT can actually be used to monitor response to treatment and for the dosimetry, which is very interesting because clearly we can't use 6 PET scans during treatment courses or for the baseline and after each cycle. So this was an interesting paper which actually evaluated acquired during step mode rather than step and shoot, and it did show very, very nice outcomes for the very nice quality of images in 30 minutes. You can see on the left-hand side PSMA scan with a step and shoot mode and the half-time ADS scan. So the dosimetry is important, and it's been really featuring this meeting, but as I would say we need more data on that. So I only showing very few studies because actually even if you have just 100 patients in year, 600 PSMA scans, time scanning would be 700 hours, and if we use a faster scanning, then we can reduce that and possibly have like 2 PET scans and 4 fast dosimetry scans. But now we are actually coming even to faster speed. We have fantastic technology, SPECT CT, CSA T, total body. There was a great symposium run by Richard. So basically, if you are having an interest in that, you know whom to ask. And this is something, this slide from the previous speaker, because I think it's very important to reiterate that actually we can be fast and we can produce really good quality scanning for dosimetry. For example, in this context, 10 minutes PET CT and 12 minutes lutetium PSMA SPECT CT, or even to quantify and basically predict outcome or assess response to treatment, as in this case. So actually very fast, which will help with the workforce, which we'll come to at the end of the talk. So this is the same, but in different context for Lutathera, that when we have a 64 copper dotted tape PET CT, is 20 minutes, while lutetium 12 minutes versus FDG 8 minutes. And I'm not going to explain this slide because you already heard about that. Our radium, you're very much using radium, and I don't think it's going to go when we have a PSMA. That's my personal opinion. We did see just before previous talk about the bone metastasis can behave differently. This is alpha treatment, it's bone targeted, might actually very well combine with our own beta emitters, which we haven't explored properly, and that is something which we need to research on and to provide more evidence and work as a community to actually do multi-center trials. And this is a very nice paper because actually, although it is confirming what's been already published, it's confirming in real-world evidence when actually you have a patient with a alkaline phosphatase that is baseline normal, they have a best prognosis, particularly if they actually even having a decline in alkaline phosphatase only after 1 cycle. It's very practical because we should be all using alkaline phosphatase to monitor response to treatment to radium. And if you actually can assess after one cycle whether the patient will respond, that's very helpful. And this clearly shows that in patients who have a normal baseline alkaline phosphatase have a best prognosis. If they actually respond on an alkaline phosphatase level as well after one first cycle, they have the best survival. If they have a normal baseline alkaline phosphatase with approximately less than 10% alkaline phosphatase decline, they still have a good survival, but not as best as you actually, if there is a biochemical response. And if you have an elevated baseline alkaline phosphatase more than 10% and alkaline phosphatase decline, they can now have a worse survival, but still better than those with elevated baseline alkaline phosphatase with no response on alkaline phosphatase. So basically, it's really good for the clinical practice for those who are doing radium to have idea how your patient is doing even after first cycle. So next is rhenium. This is our next therapeutic, which is currently used in Europe in some centers, but we have a first experience from King's, which was lovely to see during this BNMS meeting. And basically, they also talk about radiation protection considerations during applications. And this is very practical treatment, easy to apply, but treatment time can vary between 30 minutes to several hours as required to reach 50 grays. Skin contamination is rare because the product is viscose and unlikely to lead to drug contamination, but if it does happen, then there is potential for high radiation dose. So basically, need to classify operators handling 188 rhenium. So, and it's actually having really low range of recurrence for SCC and BCC, only 1.5%. In comparison with conventional radiation therapy, 9 to 10%. It's painless, improved cosmetic outcome, and effective, similar to surgery. So another dosimetry and improving accuracy of significant underestimation is if we actually include a partial volume effect. It's important to include partial volume effect because it seems that it could potentially underestimate radiation dose to particularly parotids and kidneys. This is just to really show that we have a large area of dosimetry that needs to be explored. And also the very interesting session, Too Hot to Handle, is basically an analytic approach to skin dosimetry of alpha-emitting radionuclides. And clearly we know that alpha particles don't contribute to those at the basal depth of the skin of 70 micrometers. However, we need to think about daughter radionuclides because in case that we have a contamination of the skin, then it can be actually, we can be receiving much higher doses than we are thinking, and therefore arm sleeves and face visors are essential. And this is from Sari, I think very practical because it's just closed system drug transfer device for radionuclide therapy, and I'm sure that team from Sari can actually share their experience with us, and maybe for some of us who are considering to implement the same, because it is a minimizing risk of radioactive contamination, decrease in overall work uptime, but improve radiation protection, which is very important for staff, patients, public, and the environment. And they're now considering to do it for PSMA as well, and for DOTA therapies. So Professor John Wolseley is leading on several initiatives together with the different groups, including CT-RAD and also NIHR, MRT National Research Consortium. And just want to use this opportunity to re-announce that there will be a meeting on 30th of October, just before our autumn BNMS meeting, and you are all welcome. Because we are really trying to promote research and enable access for patients to our molecular radiotherapy. With regards to CT RAD MRT working group, they try to maximize quantity and quality of life of patients that are receiving radiotherapy by optimizing tumor control and minimizing toxicity. So from that on, I will move to cutting edge, and Andy will take over for the next part.
Thank you. So we heard about some of the technological developments in our field. There was a dedicated session on motion management in PET-CT and another session on the premise of AI in nuclear medicine. In the profit papers, there were some interesting papers covering the utility of PET-CT for extracting additional information that's not routinely reported that may be a ticking time bomb for the patient. And there was also interesting work about automating imaging processing in departments which may lead to bigger efficiencies, and some nice work from the KCL group about using deep learning with neural networks to generate pseudo-CT from MR data in PET-MR to potentially combine two examinations into one. And then we had cutting-edge plenary sessions about total body PET-CT and also FAPI imaging, which we'll hear about. So this nice work from the Bath group, which again has just been awarded a prize. So it's nice to know that we're all talking along the same lines. This work was looking at patients having PET-CT for suspected large vessel vasculitis, and also looking at various metrics in the vascular tree. In particular, a few years ago, there was this article in the British Journal of Radiology, which was a consensus statement from the British Society of Cardiac CT and the British Society of Thoracic Imaging, really as a plea for people to not ignore cardiovascular calcification and aortic valvular calcification, which are significant harbingers of future doom for patients that we are very good at not mentioning. And in this study, they looked at approximately 50 patients who'd had PET-CTs, and they found that 3/4 of them had coronary artery calcification, about a quarter had aortic valvular calcification, and 6% of them had thoracic aortic dilatation. And guess what? Only a tiny handful of that was reported. So we really should be making more of what we're doing, because this has a real potential burden for patients down the line. This was another really nice piece of work from Sally Barrington and colleagues at KCL, looking at assessing healthy tissue metabolism on patients undergoing sequential imaging during treatment for lymphoma with FDG PET-CT. And we know not enough about healthy tissues in cancer patients, but there is an increasing awareness that there are cancer-associated inflammatory cytokines which can be influenced by some of the anti-cancer therapies, and you can potentially monitor this using FDG PET-CT. It's again something that we are not routinely doing in clinical practice, but in this study they looked to assess healthy tissue metabolism in the bone marrow, the spleen and the liver during chemotherapy, and associated that with the metabolic tumour volume and clinical parameters of hematological metrics, and associated these with treatment outcomes. So relatively simplistic ways of measuring using volumes of interest dropped over organs and the bone marrow. And they found that there were significant changes during chemotherapy in all of these areas. Uptake in the bone marrow, spleen and liver was associated with early hematological adverse events, so you could potentially predict patients that are going to run into problems. And as we all know anyway, bone marrow uptake is prognostic in Hodgkin's lymphoma anyway. So this is a potential marker for toxic effects of treatment that we could be flagging up when we're analysing these patients. So I think we need to think more carefully about what we're looking at when we read these scans. This work by the Sheffield Physics Group that was also featured in a workshop was around their novel approach to automating image processing in their department. They identified that there was a problem in that they had an increasingly wide range of protocols, both for research and clinical applications, and varied archiving methods, etc. And they were operating across a number of different sites. So what they wanted to do is to try and automate the whole process as much as possible to reduce the risks of human error, of things being forgotten, and to increase efficiency and reduce variability. So they set up a server array, basically, which collated all of these across their system, and it flagged up any unprocessed or missing studies which could then be prioritized. And they actually partnered with MIM using MIM Assistant and created a meaningful infrastructure so that they could automate this whole process. And this is, another example of how AI may have fairly profound impact on our working lives, above and beyond replacing doctors, which I don't think it's going to do anytime soon. This paper that I alluded to was from the KCL group, and it looked about training a deep learning model using MRI scans from PET-MR to create a synthesized pseudo-CT so that you get the attenuation values. And they were able to create visually very representative CT images from that data. And it had a good performance, and they found that it was generalizable across the test data set. They then went on to see whether they could apply this clinically in the setting of pediatric patients, where often these young children need a general anesthetic, and they are having separate MR and PET studies. So could they do a single study and generate CT from the PET-MR? And the long and short of it was, yes, it looks like this is feasible. There were some minor tweaking issues, but generally it looked to be a favourable way forward, so a nice application of a use case of AI in the clinical workflow. And we then heard about the premise of total body PET, which is coming to centres in the UK in the near future. And we had a talk from the MRC who highlighted that the government had heavily invested in research and innovation. In particular, they'd agreed to fund £32 million over the next 7 years to establish 2 total body PET centres, which would be part of a collaborative network and the beginning of a new research energised focus. We also heard from Marcus Hacker from Vienna about his initial experiences with having a clinical system installed, and very interestingly he spoke about looking at the underlying normal tissues in patients and seeing whether there were other aspects on the studies that could be interrogated, and found really intriguing correlations. So for example, in lung cancer they found that patients that had increased bowel activity had a poorer outcome, and there seems to be some sort of tumour-driven process. So these kinds of things are really the source of inspiration for future experiments with these total body machines, and opens the door for whole body screening. So with that, I'll hand over to Sabina.
So now we're going to final part of highlights, which is in relation to something which hasn't been developed yet, which is JPET, which is basically using plastic scintillators to produce total body PET CT and also trying to do positronium imaging as well. So I think these new technologies will be very useful in actually imaging new tracers. So the final bit of our talk is actually on new tracers and also on old tracer for new purpose. I think most of us were there for annual lecture, and that was fantastic lecture. Might be confusing message because we had today a message from Andrei Yagaru of FAPI cannot detect early cancer, but that's not unusual because it's imaging not cancer cells, then actually microenvironment of the tumor. And we also heard a little bit about lutetium FAPI as a theragnostic couple. And as you know, that FAP is actually expressed on a membrane on activated fibroblasts as important molecular target for different interventions, drug interventions, as well as the PET diagnostic and radionuclide therapies. So it is basically used in oncological and non-oncological indications, and now we have a developing FAPI radionuclide therapy, which is promising for radioiodine refractory thyroid cancer, breast cancer, and might be for other cancer types. So FAPI in comparison with the FDG is actually better for many oncological diseases, and here we can actually see the spread of the cancers that are actually involved, and interestingly, cancer of unknown origin with metastatic disease is actually highest expression here. But as you can see, there are multiple cancers. Head and neck is very good because of the low background. We heard about pancreatic cancer, ovarian, esophageal, particularly GI cancers. Clearly, you might notice lymphoma is not on this list, so FDG is going to stay for some time, definitely. In non-oncological indications, it's also very useful in cardiovascular imaging, musculoskeletal imaging, inflammatory imaging, particularly IgG-related disease, when we could see that multi-tracer imaging can help in monitoring response to the treatment as well. And this was very useful, a review article to actually read if anyone wants to find more. And with regards to theranostic experience, we usually say we treat what we see, but actually not always the case. And in this case, we actually don't see cancer cells. So, and it's not so potent targeted treatment as our other treatments, and therefore they had to change chemistry and some dimer in order to be actually more feasible to target cancer cells. But it still works. It seems there are preliminary data for breast cancer, which actually you can see here a really widespread disease and quite impressive response. And in the UK, we could see there was the first FAPI labeling reported at BNMS from Edinburgh. It was apparently very hard work, but it's worth doing, of course. And I think this is very interesting because in context of this, if we are treating tumor microenvironment, there might be a role for extracellular vesicles and DNA fragments in the non-targeted effects of targeted radionuclide therapy. Because prolonged exposure to targeted radionuclide therapy can actually induce bystander cytotoxicity and the immune response. And that was very elegantly presented by Jean-Pierre Paget. Again, from Samantha Terris, she comes every year with a new good paper. So this was a combination treatment, which we actually all thought that might work, and we still need to explore that in prospective trials in vivo in patients. But these are data from in vitro, which are actually suggesting that DNA synthesis disrupting chemotherapies in vitro can enhance lutetium dotatate treatment because they are actually increasing SSTR2A expression. And basically, Samantha is suggesting that we might easily look into that copy-paste methodology towards other diseases. So combined chemomolecular radionuclide therapy will be useful in many cases, and for that we will be most likely needing using multi-tracer imaging to select patients. So development of new tracers, we heard a few talks from KCL, and thank you KCL for submitting and having a POW pitches, and I think we now planning to have POW pitches for every year during research session, because it's very important that translational, basic science and clinical clinicians come together and actually think of the use of the new tracers. Michelle Ma presented her dual theranostic couple for 99 and technetium and rhenium 188 for PSMA, which definitely works in preclinical world. So basically now we just need to see how we are going to move on with this work. We had fantastic talks from Raphael from KCL, and this looks particularly promising. It's zirconium oxide cell radio labeling for PET cell tracking, and clearly if we could label, for example, T-card cells, or that would be fantastic, but for that we might need total body because of radiosensitivity of T cells, or like liposomal drugs, exosomes, or MSCs. So I think this is potential for further direct application in human, because it's ready to go, and it's a kit which is already prepared, as well as another kit which is a gallium labeled biphosphonate PET trace imaging for extraosseous calcifications. We saw papers during this conference on which Andy just presented one of them, with cardiac aortic calcifications, vascular calcifications, and maybe in some metabolic diseases it would be very useful tracer. And the old tracer for new purpose, my favorite tracer, I have to say, because it is so powerful tracer, because actually washout of the tracer is related to ABC proteins, and basically therefore in this context we are looking to differentiate between benign and malignant tumors, because malignant renal cell carcinomas expressing high level of these transporter proteins, which are quickly washing out maybe from tumor, and therefore they appear as a negative, while benign oncocytomas would appear as a positive. Hannah Warren presented her work, and from RAL3 they had already preliminary data published on 20 participants with a high sensitivity and specificity. Of course, this is very small, limited population, and therefore we are moving to multi-center feasibility study, which Hannah secured funding with her supervisor, and already 5 centers are included. So hopefully next year BNMS will have some results from this NIH-sponsored study. And I think this is fantastic, unique opportunity for the UK, and Jennifer Young presented it because there is potential to develop theranostic pair lead 203 and lead 212, and as you can see, some preliminary data already that basically it can work very well, and most importantly, we would use nuclear waste material, so really recycling rather than creating a new waste. And just to finalize that, we also have a CAL opened currently, research dedicated facility, cyclotron radiochemistry laboratory with the multi-user radiochemical synthesis facility for molecular imaging. So, but coming back to similar slide, we are too busy. We are working for NHS, the most of us, and we unfortunately very often feel that we are losing this opportunity of innovation and opportunity for further research. But we really need to resist. We need to be there for all these new innovations and the strategic platform for new modalities. So workforce planning in nuclear medicine featured this BNMS highly, and basically we had several sessions. So we need to all get involved. Our technologists need to be recognized. There is a register of clinical technologists now. We need to embrace our nurses in nuclear medicine, and also career progression in nuclear medicine is really important for our technologists, radiographers, and nurses, and it was very nicely presented by Luisa Pereira. So James Scaffam also presented the UK several medical physics experts, and we know that we don't have a scientist, we're really lacking infrastructure. Charlotte, thank you, Charlotte, for doing this brilliant work to get new training posts. You can see this was increased for radiology training post, and this was just flight line for nuclear medicine. And now we managed through SAC, led by Charlotte Farlow, to get 8 new posts, which is actually 50% increase in nuclear medicine physicians' numbers. And I think we do need to education. I'm coming to Tony Blair now. But I think it's important because, we're also trying to incorporate all different professions, and we developed now nuclear medicine course, which is subject to validation of University of Sussex and Brighton, and it's course for all professionals in nuclear medicine, and there will be 6 clinical modules, 5 of which nuclear medicine physicians are obliged to take as a knowledge-based assessment, but there are also some professional modules such as communication, leadership, which basically can help with the career developments for our RTN group, for example, and the research module if you would wish to undertake MSc. And we have now really proactive trainees, which this is the first time that we had the national NM teaching program, and they set up that program together with their specialty training director, Josef Mendichowski, and also fantastically organized career session networking by Stuart Redman. And coming to conclude, we know that we're missing workforce. We could try job sharing opportunities, and we should skill mix. We should offer job sharing opportunity to within scientific community, but also within advanced practice. But we do need investment in workforce as well as in our infrastructure. But it's great news that we actually got investment in infrastructure, at least to start with. And we covered very lot so quickly. So if you watch, please go to YouTube, run by Simon Hughes. And I would like to acknowledge SEC chairs and entire SEC committee. And thank you for the invite. And of course, Charlotte and Caroline and Manish. Thank you, Manish, for filming and for helping BNMS. Andy?
Great, thank you very much. So I thought that was a fantastic summary from our own Phil and Holly, well, when the relationship was better. But no, great, a huge amount of work has gone into that, and I've learned a lot, and I'm going to be claiming some CPD there. That was, very good, thank you. Yes. So it's my honour to present some certificates. Thank you very much. To you, and Andy. Sorry, so it's my duty to close the meeting. I'd just like to thank you all again for an amazing time as President, the support you've given me. I hope I've delivered something for you all. I've got so many people I'd like to thank, but to name a few, obviously Charlotte Weston, Caroline Oxley, Karen Walsh in our office. I'd like to thank Julie Crosdale, our incoming, our president now, I mean, Julie's done a fantastic amount for the BNMS over the years. She was an amazing treasurer, and I'm sure she'll be an even better president. I'd like to thank our other officers, so Stuart Redman, our honorary secretary, who's done so much of the meeting today, and my colleague who I work with in Bath. I'd like to thank Gianni Canari, our new treasurer. He couldn't be here this year, but Gianni's been doing a huge amount behind the scenes and is trying to improve access to our organisation, because we're actually accumulating a reasonable amount of money, so he's looking at how we redistribute that in ways to promote people being able to do things in the BNMS. And I'd also like to thank our immediate past president, John Buscombe, for all the great work that John has done. He has been absolutely driven in the molecular radiotherapy field, particularly of late, and has produced a lot of good output. So thank you all for coming. We're in safe hands. I look forward to watching how things go from council. I've got 1 year left on council, but I'll be continuing to be involved in nuclear medicine, including. So final thing, I'd like to thank Vineet and Brent for our most amazing meeting. I think you'd all agree, so round of applause. I think they may have gone. Right. Off your train.
Yeah.